To those who have joined us, my name is Heather Whitson. I am calling in from Duke University. And if you're just calling in, please your phone lines on mute. We're getting a little bit of feedback. This is the first in a series of webinars that are being hosted by the Dissemination Workgroup of the AGING Initiative, which I co-chair along with Leah Hanson, who is in the HMO Research Network. Just to give everyone sort of a brief orientation, so the AGING Initiative is a new R24-funded initiative which is led by Jerry Gerwitz. It aims to advance geriatrics infrastructure and network growth with focus on research that's related to multiple chronic conditions. So specifically, the AGING Network is harnessing the power of two well-established and complementary resources. And those two national treasures are the HMO Research Network, or the HMORN for short, and the Claude D. Pepper Older American Independent Centers, or the Pepper Centers for short. So in future webinars, we will go into more detail about the AGING Initiative and the opportunities for collaboration and cross-pollination between the HMORN and the Pepper Centers. But first, let me take just a moment to sort of orient you to the webinar format today. We're going to have a presentation that's about 30 minutes long, and that will be followed by a question and answer session. So at this time and during the presentation, we'll ask you to please ensure that your phones are on mute because we do get some feedback with the software. And then during the question and answers, we welcome your participation. So during the question and answer session, you should be able to see on your screens, those of you who are joining us on the webinar, in the upper right-hand corner, there is a participants icon and a chat icon. Under the participants icon, you have a little of tabs. One of them is a little hand. If you click that tab, you're effectively raising your hand. So if you raise your hand with that little icon, Boyd will call on you in turn. Another way that you can submit questions is using the chat icon, and under the chat icon, you can first select from the drop-down menu if you want to submit your question to everyone, or if you want to submit it just to the panelists. And if you choose panelists only, then myself and Cynthia will be able to see it, and we'll present your question in that way. I'm going to move now to our program. So in addition to the fabulous resources and expertise that's housed within the HMOR Research Network and the Pepper Centers, another great asset of this AGING Initiative is our External Advisory Committee. So the advisory committee is made up of experts and thought leaders in aging research and in multiple chronic conditions in particular. And we're fortunate to have two members of our advisory committee, Dr. Mary Naylor and Dr. Cynthia Boyd, having this call today. So Cynthia Boyd will be serving as the discussant. She's an associate professor at the Johns Hopkins University School of Medicine in the Department of Medicine and the Department of Health Policy and Management. Cynthia trained in internal medicine, geriatric medicine, and epidemiology. She did groundbreaking work related to improving care for chronically ill and frail older adults living with multiple chronic conditions. And in recognition of her significant contributions to the field, she's received an Outstanding Achievement in Clinical Investigation Award from the American Geriatric Society. Last year, she also received funding from the Patient-Centered Outcomes Research Institute, an exciting project that's entitled Informing Patient-Centered Care for People with Multiple Chronic Conditions. And this venture will lead to better systematic review processes and guideline development to inform the care for people with MCCs. Here today is Dr. Mary Naylor, and who is the Marion S. Ware Professor in Gerontology and the Director of the New Cortland Center for Transitions in Health at the University of Pennsylvania School of Nursing. For the past 2 decades, Dr. Naylor has led an interdisciplinary program of research designed to improve the quality of care, decrease unnecessary hospitalizations, and reduce healthcare costs for vulnerable community-based elders. Dr. Naylor is also the National Program Director for the Robert Wood Johnson Foundation Program, Interdisciplinary Nursing Quality Research Initiative, which is aimed at generating, disseminating, and translating research to understand how nurses contribute to quality patient care. Dr. was elected to the National Academy of Sciences Institute of Medicine in 2005. a member of the RAND Health Board, the National Quality Forum Board of Directors. We're excited to have her speaking with us today regarding her pioneering work involving Transitional Care Model, or TCM. And I'll at this time mute my line and ask everyone else to do the same, and thank you, Mary.
You may be muted.
I'm muted. Anyway, thank you, Heather and Cynthia. I am delighted. I was following directions and kept my phone on mute, but I'm delighted to be joining you today for this conversation. Let's get started because we have a limited time together. So we're going to talk today about an area of so in our first slide, an area of delivery, I think, that has received a tremendous amount of attention recently for good reason. This is about transitional care. As we think about transitional care, in the American Geriatric Society spent some time thinking about what it meant, talked about services and environments that are designed to promote continuity of care, avoid preventable poor outcomes among especially at-risk populations as they're moving from one level of care to another among multiple health team members and across settings such as hospital to home. Many of you are in environments that know well how important the case transitional care is, has been, and I think for the foreseeable future will be, especially among chronically ill adults coping with multiple conditions as well as other health and social risks. We still have very high rates of medical errors. I had a postdoc a few years ago who took a look at the medication error rate for patients with failure who were transitioning from hospital to home and found a 70% documentation rate in medications for this very at-risk population. Hundreds of studies have talked about patients and family caregivers' unmet needs, poor care experiences. We still, although improving, have very high rates of preventable rehospitalizations. Most recent data suggests a decline of about 0.5% to 1% in 30-day readmission rates, but they're still very high, and they're especially high among the most vulnerable of our older adults. The story that's been out there in the New York Times and Wall Street Journal is about the huge cost burden associated with avoidable hospitalizations, but I think the untold story is about the tremendous human burden, what it's like to be someone spending about 6 months or a year moving in and out of emergency departments and hospitals. So on the next slide, we began as a team to think about, well, what do we know? We've known about the problem now for a few decades. What is it that the evidence is telling us about solutions? We were fortunate to be able, and this is now a little dated, but a publication in Health Affairs in 2011 that took a look at that time, available evidence, most rigorous being the randomized clinical trials, and these interventions focused on chronically ill adults who were transitioning from hospital to home. We learned at that time was that we have some very good news. 9 out of 21 RCTs demonstrated improvements in at least one rehospitalization measure, either improved the time, or I should say increased the time from hospital discharge to first readmission, or decreased rehospitalization rates. And importantly, also demonstrated improvements in other health outcomes such as functional status, symptom status, and perceived quality of life. So what did we learn about the nature of these interventions? Well, we learned that they weren't simple, that these interventions were multidimensional. They often spanned settings, taking people from a post-acute environment to their home, from hospital to home. So the interventions themselves realized and aligned with the patient's experience, with the family caregiver's experience, not with a door-to-door approach to care delivery. The other dimension that was common among the effective interventions is that they relied on teams, on the gifts that each of us bring in each of our different disciplines. Again, at the time, the 9 out of 21, most of them relied on nurses as the hub, as the quarterback, helping people navigate care among multiple clinicians, hospitals, primary care, et cetera. Next slide. So unbundled these interventions, you figured out, I should say if you bundled them, you figured out that there were two basic directions moving care delivery forward. There were most interventions that were focused on addressing common gaps in care, the breakdowns in communication that occur between care delivered in the hospital and back at home, between acute care service deliverers and primary care deliverers, improving transfer of information, kinds of solutions, and encourage you to all mute your phone. Kinds of solutions, though, that were beginning to emerge at that time and I think have taken root are those that say, look at this interruption in care as manifest by an emergency department visit or a hospitalization represents not just a time to improve that experience, but really look at what is the root cause. Why is it that Mr. Smith has been in a hospital for the last 3 or 4 times in the last 6 months? What is the common cause here that we can now, during this experience, begin to address to have longer-term impact? And that's where our approach to care has evolved. Next slide. This gives you a sense of what the transitional care model is today. And believe me, this is not where it started, as Heather said, a couple of decades ago. But we screen. We have now identified pretty successfully who among those coming into different environments are at high risk for poor outcomes and who will continue to have this common experiences, preventable poor outcomes going forward unless we stop it. We learned a long time ago the critical importance, and this was largely through failures, the critical importance of engagement. Now that's a common word, but we figured out that if we didn't actually engage the person, the older adult, and their family caregivers in the entire plan of care, that it was not going to stick. We also learned, and Cynthia Boyd has been a great teacher of ours, that managing symptoms is extraordinarily important. It's not just managing diseases, but understanding how their interaction influences what is the expression of those multiple conditions in a given individual. And so we had not been, as a healthcare system, as effective in managing symptoms, and this became a very large focal point of our work. Only when you do that effectively do you get to be positioned to educate, promote self-management. The other principles that guide our model are things that all of us learned in medicine and nursing and social work, every 101. It's about teamwork. Continuity matters. Coordination is more than just getting a person from point A to point B. And all of this is grounded in trust. In many cases, our role is to reestablish trust in a group of patients who have long ago given up on our care delivery system. Next slide. So I once again encourage you to mute your lines so everybody can hear the conversation. So the unique features of our model, now I'm just going to talk about the hospital to home, but we've extended this work to primary care, long-term care, but if you're thinking about hospital to home, the care is both delivered and coordinated by the SIM advanced practice nurse. Master's prepared nurses who begin to work with people at the point that they're identified at high risk. So in this case, it might be hospital admission, who work with the care team during that acute stay to prevent the common things that go wrong during acute hospitalizations. That same nurse follows the patient, is referred into a post-acute sector, such as skilled nursing facility, and then into the home, substituting for traditional home care services. So this is the kind of continuity that people have told us over the years that they want, and really assure that they have the trust that they need in our care system. So the care is in the hospitals, in skilled nursing facilities, in homes, 7 days per week, now guided by a robust evidence-based protocol. We know the things that go wrong within 24 hours commonly go wrong within 24 hours after hospital discharge. We know that 10 days to 2 weeks post-discharge, patients are at a low ebb physically, emotionally. We don't know the causal reasons for that, but we have followed and tracked what's happening, and therefore know that this is a very important period or time of outreach. And we've supported all of our work over the years with decision support tools. So we have a risk screen, an assessment tool that helps to identify the priority needs, 2 or 3 that, if unaddressed, will likely continue to cause poor outcomes. Next slide. So the core components of our work it's holistic. It recognizes that progression of medical diseases contribute to poor outcomes, but are often not the main reasons. There are social risks. There are limited access to community-based services. It is a family-centered approach. Family caregivers, broadly defined, have to be fully engaged. It is nurse-coordinated but relies on an entire team, protocol-guided but relies on clinical judgment and individualizing and personalizing those priorities. It places a high premium on streamlining, taking very complex plans, very complex medication regimens, and getting them as simple as possible, collaborating with all of the clinicians involved to get 10 or 12 meds down to 7 or 8 prescribed daily meds. Single point person across the episode. We've built information and decision support systems, and again, our focus is long-term impact. Next slide. In the work, we had multiple NIH clinical trials, randomized clinical trials that demonstrated consistently that we can do better, that with a population living with multiple chronic conditions and all of the other complexities of life associated with that we can improve access, reduce errors, improve the experience with care. At the same time, we can improve health outcomes. So over multiple randomized clinical trials, as we were getting better, we continued to see improvements in these outcomes. Now, over these clinical trials, we were able to demonstrate that you can not just reduce readmissions at 30 days or in 6 months, that you can get to long-term impact. And this, by the way, is our definition of value, improving the experience with care, health outcomes relative to the investments that you make, doing that for long haul. So in our clinical trial, you'll see here at 52 weeks, significant reductions in hospitalization rates. And of course, once you do that, you reduce total cost of care. The next slide shows the impact on total health care cost. And here we're not just looking at costs of hospitalizations, but all costs of visits to physicians, for post-acute services, hospice services if referred. The only cost factors that we did not take into consideration were medication cost, out-of-pocket costs. And we added in the additional cost of the intervention because this was not being paid for. This was innovation that the current incentives did not align with, and so we added those in. And even when you did that, we came to significant reductions in cost of care. So we sat back, we had published this in all the right places, we had a great deal of publicity, and we waited for all of the STEMs represented on this phone to pick up the evidence and roll with it. It didn't happen. So in this slide, we began our journey of translating evidence into practice. We began working with specific health systems and specific payers to say, could we replicate what we had learned in the clinical trials in the real world? Could we achieve the same clinical and economic outcomes that we had demonstrated? We had 5 foundations simultaneously fund this effort, and our work was in partnership at that time with Aetna and systems in the Mid-Atlantic region. Next slide. So one of the things that we learned immediately was how absolutely naive we were. This was not running a clinical trial. This was now saying 3,000 miles away, what is it that we needed to develop in terms of tools of translation? So we had to build robust screening and recruitment tools. We built ways of helping to prepare nurses and teams in diverse health systems and communities in how to implement this model. We had to build a consistent documentation and quality monitoring system. We had to build a consistent quality or performance improvement system. In our case, it is grounded in root cause analysis. The one thing we knew how to do at the time was evaluation, but all of these tools had to be built so that you could provide sites with the foundation that they needed, the training, the data systems that they needed to be able to implement and evaluate this. Slide. I'll just tell you a little bit about this first project because honestly, it became a really big part of how we spend much of time these days. We built those tools and then we tested the transitional care model in Mid-Atlantic market, again in partnership with Aetna and health systems. We had an independent consultant who's very knowledgeable about organizations kind of walk alongside of us to say, what to take, what are the facilitators and barriers to make this happen in health systems. And we were very public about that. We ran into huge legal, regulatory, and other kinds of issues. But fortunately, we had some major facilitators, including fabulous champions, who said, let's walk through those problems, let's walk through those barriers, let's make this happen. And then we agreed, win, lose, or draw, we were going to widely disseminate our findings. Next slide. So good news, despite all the challenges that we encountered, and we did many, and I hope you'll ask about them, we demonstrated improvements in this real-world system in all the quality measures. This included the ones I mentioned before, function, symptoms, status, quality of life. We demonstrated improvements in both the patient and physician satisfaction with this model, with working with this model. We demonstrated reductions in all-cause readmissions through 3 months. Recall we had a much longer impact in the clinical trials, but we were really excited to have all of this, and we demonstrated cost savings for the payer that extended through 1 year, all significant. So next slide. While this work in translation was going on, we received a call from the Alzheimer's Association who said to us, look, you pick a high-risk population, but they aren't the highest risk. People with multiple chronic conditions obviously are vulnerable, but when you add cognitive impairment to that range of risks, it really adds tremendously to the vulnerability and to the poor outcomes, and that had been borne out in many, many ways. So we embarked on a comparative effectiveness study funded by the National Institute of Aging and the Marion S. Ware Alzheimer's Program to ask the questions, well, would cognitively impaired older adults and their caregivers benefit from the TCM? Recall, this is a comparative effectiveness study. We selected 2 other evidence-based interventions that have been proven effective with this population against which we could compare the TCM. These are a little bit higher now. This is not control group and standard care, but things that already had worked against TCM. Next slide. So the first thing I want to show you is that cognitive deficits that we picked up, and we had done a big sampling before this in emergency departments to see how common cognitive deficits were and published that in another paper. In this particular study, fewer than 20% had a diagnosis of dementia or delirium. High rates of cognitive deficits were picked up through a robust set of tools. And in addition, about 25% also had delirium as a coexisting problem. So these were really often unidentified problems, and even if identified, often not well integrated into the plan of care. Next slide. To demonstrate in this study reductions in time to first readmission. And in the next slide, you'll see we were also able to demonstrate reductions in the number of all-cause readmissions through 6 months. Now, recall that we had 2 interventions. The TCM was being compared against 2 others. We saw no differences in the performance of the other 2 interventions relative to the transitional care model. So for the purposes of communicating that, we showed this, we kind them on this slide. What I want you to know, though, is also look at the slope here. What you're seeing is that we had an impact through 6 months, but honestly, most of the impact was through 90 days and sustained through 6 months. We are spending a fair amount of our time trying to understand what it is that we're learning from qualitative case studies that we do with a clinical trial to know how it is that we can get this intervention better for this population. Next slide. I also want to tell you that, while this work of science building and translation goes on, our own health system decided, University of Pennsylvania Health System and others decided to implement the transitional care model as a service line. Our system decided to place the transitional care model within their home care and hospice division. If people are admitted to the hospital who need this model, the nurses, advanced practice nurses, are deployed from home care and hospice, but begin to work with the patients at hospital admission, continue to follow them into home care, help to facilitate, if aligned with the patient's goals and values, those that need access to palliative and hospice services. Now, this service is reimbursed by local payers, Independence, Blue Cross, and Aetna, and use a case rate with defined performance expectations. I'm going to be on a call later this afternoon with the IBC leaders, and they are looking at our most recent data. They want to see not performance just at 30 days, although that looks great. For example, we have at about a little over 8%. They're looking at performance at 9 months. They're looking at the long-term impact because those managed care environments are very concerned about getting to longer-term value. So we are doing this implementation in multiple health systems using a learning health system framework. We're constantly working with the clinicians, the payers, and our team to look at data and use it as the basis for continuous performance improvement. And it has been an unbelievably powerful way in helping us to continually get better in the implementation of the model. Next, we're interested in extending the model into different environments. We wanted to implement the model within nursing homes because of the very high rates of avoidable readmissions among the frailest of elders in nursing homes, in assisted living, and or receiving home care, those that are homebound, receiving long-term care services. And what we learned right away is that we knew very little about what was high value for this population. It's not the same population where you're thinking about improvements in function. Where we've landed on this is how important improvements in quality of life is for this population, as well as making better use of resources. But what we did, before we could implement an intervention to identify the markers of success of intervention, we decided to engage in a longitudinal study that is helping to identify what the experience of care is for the frailest of those living with multiple chronic conditions, those living in nursing homes, assisted living, or receiving long-term care services in their homes. And this is helping to guide how we are moving the transitional care model into the long-term care environment. In the slide, I'm going to give you one example of one of the quality metrics that we're measuring here with, again, without intervention, but just to know what it is that we will be defining as metrics of success in the intervention. Here we just are showing you or demonstrating what we're learning about depression symptoms over time among long-term, those who are new to long-term care during their first 12 months. And it helps us to know that depression, while the severity seems to get a little better over time in the current delivery system, that depression rates remain very high, moderate and severe depression over time. Next slide. So we've been very interested in knowing about how to extend the transitional care model into the community. And I'll go to the next slide. There's a study that's saying, could we collaborate with patient-centered medical homes targeting older adults living with multiple complex chronic conditions? And could we build a partnership with these patient-centered medical homes, use a transitional care model that will enable people to stay in their community and avoid emergency department visits or hospitalizations in the first place? So in this particular study, we are comparing the outcomes of a newly defined approach that links the patient-centered medical home and the transitional care model to those that are achieved by the patient-centered medical home only, and using the lessons learned from this to drive large-scale efforts. Next slide. As work continues, we've also been trying to figure out who out there in the United States is using the transitional care model, or alone, or in collaboration with other transitional care models, and what is it that we can learn from that? And so the Robert Wood Johnson Foundation is sponsoring a study of this. In the next slide, we are specifically figuring out what systems, what communities in the U.S. are implementing the TCM. We recently completed phase 1 of this work. Had over 600 respondents, health systems and communities respond that they are using some form of transitional care, and of those, 56% are using the transitional care model, either alone or in combination with other evidence-based approaches. In our second phase, we're going to do a very big deep dive to understand how adaptations to the transitional care model that occur locally, do they get us to better reach? Do they get us to better value? Next slide. I'm delighted to be part of the project team led by Mark Williams at the Coordinating Center at the University of Kentucky. I recently funded a PCORI effort, the only one funded on transitional care. This is an extraordinarily complex effort involving multiple scholars, many patients and family caregivers, and in the next slide, I'll tell you what we're trying to achieve. We're trying to ask the questions, transitional care services and outcomes matter most to patients and family caregivers. We have multiple focus groups planned over the next few months to help us to understand that, and then using that as a foundation to begin to really challenge ourselves to see, are the evidence-based transitional care services available, knowledge-based, meeting the needs that people and their families care about. And we will develop a set of recommendations to spread highly effective patient-centered care transition programs. Slide. So I know this has been a whirlwind tour, but let me summarize by saying that, our approach to transitional care focuses on high-risk, cognitively intact, cognitively impaired older adults as they journey, as they experience care across multiple settings. Our model has been, and I put it in quotes, successfully translated into practice. Communities that want to keep their older adults living in their homes, in health systems that want to change the delivery system so that it more closely aligns with the needs of people as they experience care during episodes to get to long-term value. Our model has been recognized by the Coalition for Evidence-Based Policy, which is a nonpartisan group that takes a look and informs Congress about where it is that we should be spending our dollars. So we've been recognized as an innovation that meets top-tiered evidence-based standards and that, if scaled, could have a very positive impact on people living with multiple chronic conditions while making better use of finite resources. Next slide. So here are my key lessons to you. The challenges that we're confronting are not simple. They will not be solved by any one widget on technology. They're very complex because people are complex. They live in complex environments and complex communities. That evidence is central. It was central to getting us to the doors of payers and policymakers, but it is not sufficient. That we need a new breed of researchers willing to directly partner with the end users to figure out how to make things happen. The change is needed. It's needed in structures, in care processes, in roles, in our relationships with each other as health professionals, but most importantly, in our relationships with the people who are counting on us, patients and family caregivers. So carpe diem. And I'll end with this final slide. Is a story. This is a story of Mr. Lin that was published in 1999, Washington Post, after we published a paper in JAMA. And the story followed Mr. Lin and his wife for 52 weeks after receiving the Transitional Care Model. Before this, he'd been homebound, only going back and forth to the hospital in an emergency vehicle, ambulance. But this him 52 weeks after Transitional Care Model in his garage, doing things that he loved, doing woodworking. Now, we weren't and haven't been as successful with all of our patients as we were with Mr. Lin, but he does serve as a source of inspiration to us about what is possible if we're willing to make changes based on evidence. So my last slide is a slide that is in gratitude, because this is an effort that has had the support of me, including thousands of patients and family caregivers. Let me stop and leave some time to Cynthia for questions and comments, and I look forward to hearing from you.
Great, Mary. Thank you so much. I'm sure there's going to be lots of comments and questions. I'm just going to briefly review, particularly as some people may have joined later, the different options for making comments or asking Dr. Naylor questions. So you can, on the WebEx, you can click up under participants, the little hand to raise your hand, and we will call on you in turn. If you're prefer, you can submit questions under the question and answer bullet, in which case I or Heather will read questions to the group. And if you're on the phone, we will also have time where we ask people who want to speak up that way if they're not able to do it through the WebEx, if you want to ask questions. So we're eagerly looking forward to a rich conversation. Mary, while we're waiting for folks to chime in if they want to make comments or questions, I wondered if you could speak to the way that this model has been implemented at the same time that there's been many changes, both in terms of other programs being implemented in settings or in health systems. It's a very dynamic time where there's also changes in the incentives and disincentives to do this kind of work. And thinking about how you measure effectiveness, I think this may be one of the challenges you were referring to earlier.
Thank you. I mean, when we began this work many years ago, I used to stand in front of an audience and have to define what transitional care was. And now it is ubiquitous. Ubiquitous in the sense of that we have, as Cynthia mentioned, a whole set of incentives. The Community Care Transitions Program as part of the Partnership for Patients, trying to move and out into multiple communities, hospitals partnering with communities. We have disincentives, payment disincentives for related to hospital readmission reduction. And so all of this is taking place as we're trying to move evidence forward. And it is, what we've been doing, what our team has been doing is carefully documenting the changes that are happening in organizations, in leadership, the external changes that happen as we are attempting to implement our approach to care. We are also vigorously doing this with a robust comparison group. So, for example, in the patient-centered medical home plus transitional care model, as we implemented the innovation, integrating these two care delivery models to come up with a new whole, we had simultaneously a similar group, if there is a similar group, of patient-centered medical homes, all level 3, so we tried to try very much to get rigorous comparison groups and simultaneously track changes in policy, in practice, in organizations that may affect our outcomes.
That's great, Mary. And we have a number of questions rolling in. I'm going to put two of them together. First off, saying it was a wonderful presentation, but questions about the size of the patient panel per advanced nurse practitioner, and if you could also please talk about whether it is required to have an advanced nurse practitioner to be the core transition care manager. Has the system attempted to use a care manager whose training is not as high as that?
Great. So first of all, to the first question, the size of panel depends on where in the healthcare delivery system we're operating. But thinking about hospital to home, we've carefully tracked that, and on average, an advanced practice nurse working with a panel at a point in time can be carrying in the neighborhood of 20 patients. Recall that they are working with patients from hospital admission, including visits throughout the hospitalization, collaboration with the team to make sure that people don't develop the common infections associated with hospitalization of this population, that they're in the home within 24 hours, that they're following patients each patient for an average of 2 months, substituting for traditional skilled home care. So this is not in addition to, that they're going with the patient to their visits to the community-based clinicians, whether that be a physician or nurse practitioner who's delivering primary care in the community, or to the specialist. And so that they have 7-day-per-week availability. So at a point in time, that's the, and in that context, and for that care delivery model, the average sample, panel size. So the second question, so I'm cognitively impaired now, right?
The second question was whether it needed to be an advanced practitioner.
I think that is an empirical question. I mean, when we began, what we're doing is trying to build the evidence about the best practices and to continually update our tools. And so I think it is and I hope someone will test that. whether or not now that we know the target for this intervention, how to prepare nurses, physicians, and other team members to function as a team in its delivery, how to measure its impact, what evidence-based protocol is. I mentioned, the common issues that happen. We now have them documented to guide clinicians so that they are prepared when they go on that first visit in the home. So I think it is an empirical question. It's also an empirical question about whether or not a different kind of team leading this, nurse and social worker collaborating together because of all of the community-based challenges that this population often confronts. It's not lack of adherence. It might be lack of transportation to get to the pharmacy that prevents the problem. So I think these are very important empirical questions now that we have an evidence base to make available to clinicians to implement.
I want to encourage people that if you'd like to ask your question to yourself, to click a little hand, and we'll turn the mic over to you. But as a follow-up question to that, do you find that from one of the participants, do you find that how nurses who facilitate transitions are as more effective as those that are embedded in hospitals or in the community, such as in the patient-centered medical homes, home health, and health plans?
Excellent question. Well, they're all excellent questions. So what we did find is that, first of all, the preparation of the current workforce, I think, has not adequately prepared nurses to assume roles where they have to have both depth of knowledge, as we find from hospital nurses who really can early pick up, early identify that someone's symptoms are progressing and needs early intervention, et cetera. So they need both depth and breadth so that they can really appreciate the challenges in the community, how to access resources that are often not easily accessible. So we have found the importance of training, preparation, and ongoing investment. If I were to build a team, I would have a team that is comprised of both. And we use very much, this is a learning health system model, so that you are constantly thinking about how to build a team, not just of nurses, but other disciplines, but especially the nurses working together. They present cases weekly. They talk about their success and their lack thereof. So we have training programs. Nurses that are coming from ICU or hospitals are working, and they devote more of their orientation and training to the work of nurses in the community. Nurses in the community come from the community to devote more of their individualized training to preparing them to be able to be exquisite clinicians. And it's that combination. The common ground competencies, though, excellent communication, excellent capacity to collaborate with multiple physicians often involved in the care, other health team members, in order to get everyone aligned to a simplified plan of care for Mr. Smith that matches what Mr. Smith was to achieve.
Great. So I'm not sure how well the hand-raising function is working for everyone, but I have another question, but I'll offer to see if Susan Crowley would like to read it herself. Susan, to unmute your line. We'd be happy to have you ask the question.
Hi, this is Susan. Thanks so much. It was a wonderful presentation. And I was just wondering, with regard to your program, you must have learned sort of the hard way about ways that you might influence health policy to get adopted into our health system payment sources, innovations that might help and assist patients staying home. Specifically, I was thinking more of along mechanical lines of certain innovations that have been in mechanical engineering that would allow patients to stay in their home, yet you can't get Medicare to pay for them, and hence no manufacturer wants to support them. So I was just curious to know, from what lessons have you learned along the way about how we might approach getting innovations such as your own in formal health policy and supported financially?
Excellent question, Susan. Thank you for asking. So first of all, some of you may not know, but I started in health policy. I was working with the Senate Committee on Aging and with the Finance Committee as a fellow a long time ago, and then stayed on. And what brought me to Penn was the opportunity to think about building a multidisciplinary team. So we have scholars, clinical scholars in health services, researchers in nursing, in medicine. Mark Pauley in the Wharton School heads all the healthcare economics part of the program. And our goal collectively has been to both influence practice and policy. Heather mentioned we try to get ourselves situated on as many policy groups as we can. In addition to the National Quality Forum Board, for example, I sit on MedPAC, the 17-member committee that advises Congress on payment. So to your point specifically, I am all about trying to figure out the ways in which we can create the payment policies, and I'm not speaking for MedPAC now, but to create the payment policies that allow for the kinds of innovation and adaptation that you're talking about. And I think the payment policy has to say, allow these systems and communities to figure out the best way they can to enable Mr. Smith to stay home. I've learned over the years, for example, about devices, and we incorporate them, but we've been able to do this because we negotiate with the payers that we are going to take full advantage of community resources, technological resources, whatever it takes to assure positive outcomes, as long as we also come to, and that's why the quality cost emphasis also come to being able to demonstrate we can save money by doing that. So I'm fully in support of the kind of payment policy that unleashes the possibilities for every patient and family, with the goals of enabling them to have a much higher quality of life in their homes if that's what they choose.
Right. Thank you so much.
Great. I'll go ahead and call on Alaf Kapoor, who had a question.
Oh, yeah. Can you hear me okay? Okay, great. Thanks also from my side for the presentation. I may have missed part of the nuts and bolts of the intervention, the Transitional Care Model, but could you comment on how you, with the organizations like Home Nursing, Visitors Association, and within Philadelphia or the other places where where the intervention has been implemented?
Great, another great question, because on the face of it, you would think, well, wow, this model, because it substitutes for traditional nurse services in the home, and may be seen as competitive. But we've been working collaboratively, both at a local level and national level, with home care organizations and home care associations, because I really think that this is a tremendous opportunity. I actually had a presentation recently to one of these groups where I said home care needs to reinvent itself to be able to allow and promote service lines such as the Transitional Care Model. So when we had the opportunity to work with our leaders within our own health system, I suggested the hospice vision was a natural place to situate the model, even though it was going to be deployed in such a way that it could affect care in hospitals, affect care in the primary care communities, affect care in home care. So we were able to do that. The second point I'll raise is that, am I still on?
Yes, you are.
Okay, good. I'm sorry. The second point I'll raise is that I think, have sets of rules right now about who can receive what kinds of services that don't always align with the evidence. And so part of, in an earlier clinical trial, we were able to demonstrate that over 50% of the people that we enrolled in the clinical trial that we identified as at high risk for poor outcomes, and that we were able to affect change in the course of their experience and their outcomes, that they would not have been eligible for traditional services under traditional fee-for-service rules. So, the notion here is that collaborating with the players, and including and especially home care and hospice, creates avenues and opportunities to promote broader access through evidence, and in some cases create service lines within those divisions.
Yes. So another question from Ming-Tae Seal, if you'd like to chime in.
Oh, thank you so much for this great presentation. I'm curious about if you could elaborate on the learning health system framework.
Yes.
Intervention. Do you have you developed a workbook for other organizations that may be interested in implementing this?
Great. So first of all, I was fortunate to be a member of the Institute of Medicine Learning Health System Committee, and I'd say our framework, our work in this, and I'm happy to put you, if you want to email me, in touch with Kathy McCauley, who kind of guides this work. But so, and that committee, by the way, has a model that we now have used and inserted in ours about how evidence, how questions that surface in care delivery should be very much informing the kinds of ways we think about building evidence, and how that evidence should affect both policy and practices. And so I can send that to you, and as well as our work in root cause analysis, which is really where we've been for many years, thinking and having a process that says, you share your stories, your successes, a culture, by the way, of trust, that this is, we are all in this together to get better. You share your stories, when things work and don't work, in the presence of people who can help you think differently because they're clinical experts in X or Y or Z, and system experts in X or Y, because many times you know the clinical answers and you don't know how to move or budge the system. So we've used both. So you share successes and failures using root cause analysis, and you constantly feed data. So feeding data to the transitional care nurses, for example, about their performance, not at a quarterly basis, but as quickly as you can get it. Having them generate the data themselves, they aggregate and bring back to them on the next Tuesday meeting. Having them come in with a format for their case study presentation of success and failure. All of these are tools, and I'm happy to put you in touch with a colleague on our team that is guiding that effort, if that would be helpful.
That would be, yes. I would really appreciate that. That sounds
great.
Wonderful. Thank you.
So,
we'll take one more. Quick question from James Ralston, and then I'm going to turn things back over to Heather.
Great.
Hour though, so if we can try to keep it brief.
Got it.
James?
Yeah, Mary, thank you for a wonderful presentation. It's great to hear the story on the transitional care model. It looks like a fairly intensive intervention, and I'm wondering if you've identified these folks has changed since you started, and what tools you have for identifying the folks that will benefit.
Heather, I'm happy. I was going to say, James, I will send to Heather the tools, but we have gotten actually, so in some systems, we've gotten simpler about this, meaning there are 5 or 6 key variables. It used to be a lot more, and now we've come down to 5 or 6 key variables that are helping screen. That doesn't mean that's the end of risk assessment, but helping us to screen and to know. I do want, and so I'm happy to share that with you. But I do want you, people use this. There was a piece last week in the National Journal. I would encourage you to read it. We're featured in this section called A Good Idea. But the notion of this being intensive and or costly, I think is something that, I constantly am confronted with, and I want to have a chance to say to you, it is a different approach to care, that without question. But if you're interrupting chronic illness trajectories, you need different approaches to care. So it's intensive up to get to longer-term, less intensive, less costly responses. And how we frame interventions and innovations is very important. That's probably longer than Cynthia wanted, but I'm happy to send the risk. Heather can distribute it to the network, and or welcome any of you sending a note to me. Then I can forward stuff to you.
That's Mary. Thank you so much.
Thanks, Jane.
And I want to conclude by thanking everyone for calling in, and especially thanking both Mary and Cynthia for an incredible presentation and a great discussion. If everyone will just for the future, we are in the process of planning our next webinar, and we will have at least one more this spring, so stay tuned for what that is. But thanks, Mary and Cynthia, for getting us off to a great start. I wish there was a way for me to cue applause over the phone.
Thank you. We'll take it.
All right.
Thank you.